Thank you, Minnie. So as usual, you're really kind, and most of it's very unjustified. But it's lovely to be here today, and it's lovely to see some familiar faces and some unfamiliar faces. I look forward to lots of discussions over the next day and a half. So why am I here? So I'm actually I'm a researcher and I'm a doctor, and I've always been interested in how genes sometimes go wrong and how they cause problems. But actually, I'd never worked on what we now call PROS or any sort of overgrowth until I met Mandy, and Mandy was kind enough to let us publish some of these pictures of her. She's probably tired of seeing these things.
Sometimes those make sure, I tell you. and you know, Mandy came to look. I've got this problem. I've had it all my life, and clever doctors have scratched their chins and tried all sorts of things. And I might say, you know, quite honestly, I wasn't particularly clever. It's just that technology had moved on. So instead of doing gene tests, which usually rely on a blood test, I met Mandy and we had a chat, and we thought maybe there was a problem with a gene in her legs that wasn't in her arms. And so that means a little bit more than a blood test. It means some skin biopsies and the sort of things which you know about. And we read those genes, and this is what it used to look like in the old days. These days you really won't see these colourful coloured traces. You'll just get a bit of paper back with a genetic test result in. So I won't be showing very much science at all, but this is just showing that moment when we realised what had caused Mandy's extra leg growth. And you can see that each one of these coloured peaks is a letter in the code. And actually, we all have two copies of a gene, so that's two identical copies on top of each other. And that's exactly how this little fragment of the DNA code looked like in Mandy's arm. But in her leg, you can see in the cells that we grew from there, there's a half-size peak, and it's got two different colours. And that means that one of the letters has been changed to something else. And this is an unusual situation. This means that there is, or as we thought at the time, this means there is a change in her leg that wasn't there in her arm. And when we actually looked at some of the different bits of tissue that we were able to study, we could see that this little red lump shouldn't be there, and it was there. So it's actually a very small change. That's it. That's what causes all the different types of problems that people with PROS have. It's a little misreading and a miscopying of one gene in one cell at some point as we develop. And the other thing is that's actually really common. You know, we've got billions of different letters in our DNA code, and we're all absolutely full of little changes in many cells in our body. In fact, as you get older, it's inevitable. And it's just plain bad luck that this one particular change happens to be in a gene which is involved in regulating how tissues grow. And it doesn't mean that there's sudden chaos, it just means that the bits of the body that have that gene change don't obey the normal rules, and they grow out of sync even with the matched bit of the body on the other side. And so all of a sudden it was one of those moments where, working with Mandy, we realised what was going on. And that's just a picture to show that this sort of mosaicism, that's what we talk about for obvious reasons. It's actually pretty common. It's very common not just in us, but it's common in nature as well. And there's different ways of mosaicism. But when you see sweet corn like this with lots of different colours, that's a type of mosaicism with little gene differences in each one of those. Flowers have lots of mosaicism, and that's why you can see some petals with two different colours or two different shades of flower on one plant. So it's a common thing, and it's just so when we think about this being a disease and abnormal, it's just a really bad bit of luck that one of the types of changes that happens in all of us all the time just happens to have changed something important. So I've got, actually, apart from those two slides with pictures, some of the most boring slides you'll see all weekend. Because, you know, wonderful colleagues, Rilitza, after this will talk about research, and Professor Varb, Professor Mansour, Dr. Pollowith, they'll give you lovely up-to-date talks about where exactly we are with treatment and research and trials. So I'm just going to give you a little bit of a sweep. It's unbelievably, it's only been about 10 years since we first discovered that, and other people discovered that. And I want to try to give you a bit of a shape of how the world has changed over 10 years, and then all those gaps can be filled in by other people. So, as I said, we were lucky because the technology allowed us to do that testing in Mandy when we first met her, and other people around the world were doing some similar things. And so there were a bunch of scientists about the same time who found similar types of changes in different types of conditions where the brain might be affected or the fingers might be affected or different parts of the body. And there was a huge rush after that, and it suddenly became clear that all sorts of things that doctors had described, and we love talking about syndromes, which sounds very grand, but in medicine, a syndrome just means a collection of abnormalities that happen together more often than you might expect. So that means maybe they're linked together, and maybe that helps us to study them. It's all it means, just a cluster of stuff. It's just if you sit in clinic for long enough, you spot that there are patterns of things that come together. So all these other syndromes, which have been described by doctors over the years, some of them with doctors' names attached, some of them in Latin. Skin doctors do love to use Latin, I have to tell you. And in fact, it became clear that they're all really just versions of the same thing. They might look very different, but they're all the same. And that was some of the work which Mandy talked about, which happened in the years afterwards. So having met Mandy, we quickly found a cluster of other people with similar problems in the UK or in America. And then around the world, everybody started doing this, and we started getting together and saying, well, it's not really that great for people. You know, it's very confusing for people, for families, for doctors actually, to have 100 names when actually we know the thing going on underneath is the same. And that's where we suggested using this term PROS, PIK3CA related overgrowth spectrum, and we did just some work to describe in a bit more detail the full range of it. But one of the things I learned during this time is that doesn't mean that all those other names are not important, and actually some of them are very small conditions and maybe just one doctor used them a few times. But some of them are names which have helped people to group together, people and families to group together, and groups such as this to group together as well. And so they mean something. They're a label, they're an organizing name that can help to make the case for funding and research, and so each of those names can be very important as well. So we're kind of moving towards a situation now where a lot of people are recommending that what we might say is things like PIK3CA related, any one of those syndromes, if you see what I like. But it still is a little bit of a mess. And as you go through what we call diagnostic odysseys, these long journeys until people get a diagnosis, far too long still, a lot of people will get some of these different names attached to clinical letters, and we'll hear them saying, but actually it's all the same mechanism to delete. So we try to educate people that actually, although they might affect different parts of the body, these are all the same. So this is a version of the slide actually I probably used last time we were here, whenever that was. I think it might have been 2018 the last time I was here, but I could be wrong. And this is a sort of big picture summary of what I think we know and the things that we don't know. So we know that by definition it's changes in this gene that cause PROS, although actually there are some related genes that can cause similar problems. We know that not all tissues are equally affected, and by that I mean that it's very rare to see the strong gene changes in the blood ever, although it must happen there at some point. There's no reason why it wouldn't. And so it is often blood vessels or lymphatic vessels or fat or bone or muscle. So some tissues seem to be more affected than others. We don't completely understand why that is. Exactly what the change in the gene is does matter a bit. We can roughly divide them into strong changes and weaker changes. And the strong changes are the changes which cause the slightly faster overgrowth, and it's usually a little bit more localized. There are some very mild changes which can cause still asymmetric overgrowth, but it affects many more parts of the body and is a bit milder. So there's a sort of trade-off between how bad the growth is and how widespread it is. But really, what's much more important is when this random unlucky event happens, and that could be in a finger, it could be in the head, it could be in a limb. You know, that's where most of the variability comes from. And we'll talk a lot more about drug treatments, and we know that this new discovery has identified that drug treatments are beneficial for some people, and we'll talk a little bit more about that in a minute. But there's a lot of things that we don't understand, and a lot of these are sort of important scientific things which Renitsa and I think a lot about together, and we're getting more funding to investigate this. And this is important so we understand how the condition happened. But always the reason for doing that sort of research is it might give us new ideas about lines of attack, extra things that we can add to the current treatments. But that's longer term.
But the really, the really crucial things we need to know are, of all the things in this broad range of conditions that we call PROS, we know that some of them probably are sort of fixed during development by the time somebody who has PROS is born. And there are other things which will be reversible. And then there are other things that we can stop getting worse. But we need detailed information, unbiased information about what this is probably the single biggest question. And that's really what clinical trials are for, and especially randomized clinical trials. And I'll talk a little bit more about that. So, I mean, you might tell me that there's other things in here that are important. I think these are the most important issues that all of us should be focused on. So I think anyone who has PROS, or one of those other conditions that falls inside PROS, I think they deserve early, accurate diagnosis. And we know still, even though we in this room know lots about this, there are many others who don't. And there are some people who take far too long trying to get a diagnosis. And when a diagnosis is made, especially in a child, and where we want to advise worried parents, what does this mean for the future? That's what we all want, and we often probably care about our kids more than ourselves. We need to be better at saying exactly what's likely to happen in the future, and we're still learning that, is the truth at the moment. And among nearly all the conditions I study, rare genetic conditions, common conditions, this is the one where each individual person is most unique and most distinct with most particular problems to them. And so I know of almost no other group of conditions where it's more important that the advice you get is personalized to you. In any condition, a clinical trial tells you, on average, what you should be doing in groups of people with any condition. No clinical trial really tells you exactly what you should be doing for the person in front of you. And I think in PROS it's more important than ever that particular person is treated. And then of course all the other stuff, which is not so much in my experience because I don't live with PROS on a day-to-day basis, but this is actually crucial, probably one of the most crucial things for daily life, and that's why groups such as this one are so good. And then all of us need to get out there and bang the drum and make sure that doctors and everybody else is aware of this, so partly to sort out the earlier accurate diagnosis problem. And of course we want to get better treatments, and we want to use those treatments at the right time. But I think we also mustn't define success or failure by having a new tablet which sorts everything out. We should all try for that, and that's brilliant, and we're going to hear plenty about alpelisib and other drugs. But this is one thing among all those other things which are very, very important. And so this is kind of related. So I think if I was given as much money as I could possibly have and told to make life better for people with PROS, I think the easiest one, first of all, is to make sure that all the things that we already know about are done well and are available to all the people with PROS. And this is true for almost any rare disease in the country. So there are fantastic multidisciplinary teams around the country. They tend to be localized only in one very few places a long way away. Oftentimes people haven't heard of them and don't know about them. So there's just a huge effort needed to make the case for funding and to make the services better. And the voice of patient advocacy groups, PAGs, is one of the acronyms that people talk about all the time. Really, really powerful in helping to make that happen. So that's a problem of funding, making sure people know about this, organizing clinical services, and of course money, always, in the end. And then, when it comes to finding better treatments, so any time that you find a new gene change which causes a condition, the hope always is that suddenly lights a light bulb and there's a medicine that matches that gene change. Very, very, very rare for that to be the case, because often the gene changes are complicated changes that change something in the body which there is no medicine for. And PROS is one of those examples of a condition where there are actually possible medicines that could be used. And so I'll just tell you a little bit in big picture about some of the experience of, first of all, doing what the jargon says is drug repurposing. So that's saying taking medicines which are already being used for other reasons that match up with the condition and saying, well, will this work? So sirolimus is the perfect example of that.
And then the next thing is going to companies who are making new medicines, trying to make new medicines, and that actually target the PIK3CA gene, that target the cause of PROS, and saying, why not? You know, this is a no-brainer. We've got a condition caused by activation of this gene. You've got a medicine that targets that gene. There's still lots of work we have to do, but come along and work with us to see if it works in PROS. And alpelisib is an example of that. And then, of course, further down the line, in the longer term, it's only by actually going deep into the science and some of the sorts of things which Renitza is going to talk about, that we might find new and different ways, either to add to those other medicines, to attack things, you know, really, really make a step change in what we can do. And as I said, what we all want to know is what can we reverse and what can't we reverse. And then when putting trials together, it's actually really, really tricky, again, because of all that variability, all the variability of the people in this room and beyond this room. So there is usually not a single measurement which we can use to say this is the measurement, this is the thing that we will measure to decide if this drug is doing good or not. And if we have a different measurement in every single person, it becomes very difficult to group them all together. And the other problem is that, of course, a lot of the people that we care about most and want to stop abnormal growth in our children, and they're growing as well, and children very inconveniently have growth spurts and they rocket up at puberty, and so we have to measure growth that is abnormal in the face of other growth which is happening at variable rates as well. This is all very tricky. And then the other problem which comes up, some of the big companies that make medicines, in particular for cancers, they're in such a rush to try to get to the big disease that they want to study, that they often neglect doing safety studies in children, which means that when you want to do trials which include children, there's a lot of extra work to be done. Okay, and my last, this feels like a little bit like an undergraduate lecture, I'm sorry about this. When a new medicine comes along, a new condition like PROS, and we've got obvious ideas about medicines we'd like to try. So how do we know that they work? And what sort of evidence do we need to get to be really confident to give you the right advice, and so we can persuade people to approve it? So you start off with anecdotes that, well, we found a person with this rare thing and we gave them this medicine and it seemed to work really well. And that's useful. And that's often where things start off. And that sort of develops into, so that's really anecdotes, I suppose it's just something in the corridor, but once it's written down it becomes a case report. And then sometimes you put together groups of people who've all had treatment and you share experience. But, and you'll see examples of this with alpelisib, so it can be quite disruptive, but you also have to be quite careful because, and doctors know this for hundreds of years really, everybody needs to be kept up, everybody wants these things to work, the doctors want them to work, the patients want them to work, and so there's lots of biases that come in and you take too rosy a view of a treatment. Unless you write down in advance, right, this is all the things that we're going to measure, and that keeps you honest, and then you have to say what all those results were afterwards. So these can be valuable, but they tend to err on the side of being a bit too rosy. So that's when you move into studies like the one that we did with sirolimus, where it's not randomized. In other words, let's say we gave Mandy sirolimus, and she knew she was having sirolimus, and we knew she was having sirolimus. It was still registered, and we told people what we were going to measure, but it's not quite the same. And she wanted it to work, and we wanted it to work. So all the same things apply. But in the end, it's these randomized, double-blinded controlled trials. So this means you will either get the tablet that we're interested in or a placebo, a sort of dummy tablet. And the doctor won't know which one you're getting, and you won't know which one you're getting. And that's incredibly powerful because it means there's no way of cheating, there's no way of just wishful thinking and hoping this is working and doing other stuff and changing behavior. So, but these are tricky and expensive trials to do. Oh dear, it's another boring slide, sorry about that. I don't think we need to worry too much about this. And this is all about, lessons that we've learned about, you would think if you have a condition where we know what the gene change is and there's a company that has a candidate medicine that might work, they will fall over themselves to come and work with you. But actually they're very busy people and everybody wants to work with them, and we've learned that you actually still need to get behind the front door and really enthuse somebody and do a sort of big PR campaign. So, and then they will always think about This is just some scans to illustrate some of the points about designing studies. So this is just some MRI scans, which are slices through people, and shows you some examples of a leg which is unaffected, and a leg where there is a lot of extra fat tissue, and lots of other examples of things that are very asymmetric, and nearly all of those are in children. And so both legs are growing healthily, but one of them is growing more than the other. And just an illustration of how careful and how tricky it is. So, way back 10 years ago, after we met Mandy, our first thought was, well, this is great. We now know what the cause of these conditions are. And there are medicines around which might work. And some of the first things, we actually grew some little cells from Mandy's skin. And we showed that lots and lots of these medicines were terrific, and in the lab they could turn off the problem very quickly. So that was very encouraging. And that's when we went out and we didn't want to mess around. We wanted to go to the medicines that we could try to give to people as quickly as possible. So that's why we did our first study of people with sirolimus. But we were really interested in these other medicines as well, through the ones that we looked at, which were not yet available in clinics, but which were being used by companies in cancer. You see, alpelisib is one of those. Another medicine here called tazolizumab, and all of these work very well in cells, but that's when we had to start sort of fighting behind the scenes to get access. And I'm not really going to talk in detail about all the medicine trials. This was a trial that we did together with Professor Rob, who's going to be, I don't think Pierre's here. He's going to be here later on or tomorrow, I think. He's been one of the colleagues in France who's been involved in this work, and colleagues in America. So, first of all, we tried sirolimus, and that's one of those medicines which is around already, so we could give it to people. And because it worked very well in the lab, we just didn't know what was going to really happen. Was this going to suddenly shrink everything down? Was it going to do nothing? Was it going to cause problems? So this is one of those things called a pilot study. So we watched people for 6 months, and we gave them sirolimus for 6 months. And the answer was, it maybe did a little bit. It certainly was nothing like up towards our most excited possibilities that it would shrink everything down. And all we were really measuring was the extra fat tissue, and there were reasons for that, because sirolimus soaks into fat tissue very well. So our conclusion after doing this study, and other people have had similar experiences, was sirolimus probably does a little bit of good, not nearly as much as we'd hoped. This was just 6 months, and so it may well do a lot more good in the long term. Also, it may be particularly good for different bits of prose that we didn't study, and I think there is reasonable evidence that it is more useful in some of the types of vein and lymphatic malformations. So sirolimus certainly has a place, but it's not the big answer that we had hoped it might be at the start. So it may well be that some of you are or have been taking sirolimus, and that's fine. And once again, I think it's very much a matter of working out individually if it is giving benefit. And what we also, sirolimus is used in clinic a lot, and a lot of our colleagues said, oh, sirolimus is fine, we use it all the time in people who have kidney transplants. And actually, we did find, when we looked carefully, we found a lot of people who had some side effects from sirolimus, mostly mild, some of them a little bit more serious. None of them were unexpected, they're all known to be side effects for sirolimus. But actually, some of them were quite unpleasant, and it's just a reminder that it's really important to weigh up the pros and the cons, and that's what these clinical trials are about. So we looked at the properties of the other drugs, and we were really interested in alpelisib, and we tried to get the company that makes our alpelisib to work with us, but they just, for whatever reason, maybe we didn't speak to the right people, maybe we weren't persuasive enough at the time, they didn't want to do anything else. Whereas the company that makes tazolizumab, a related medicine, was incredibly enthusiastic. I think we just found somebody, we told them the story, and it caught their imagination, and they were terrific in helping us to work up a different trial. And again, we started this off, but then it was mostly done in France by Professor Rob and colleagues. And this was different because this actually hits the gene itself, the PIK3CA gene itself. But the long and the short of it is we had to stop the study because it had some nasty side effects. And looking back at it, back in the end, we think the side effects were coming not because of what it was doing to the particular gene that causes PROS, but because it has a little bit of an action at a related gene, and that was causing problems with the immune system. And so it just emphasized why alpelisib was probably a better option in the first place. But this looked very good in our cell studies, We did the trial carefully, it was registered and we stopped it when it was causing problems, and so that now this is not being developed because of those problems anymore, so that was a negative. And in the meantime, Professor Cano in Paris was kind of quite disruptive in the sense that this wasn't one of those studies which was pre-registered and goes through all those rules that I talked about. This was really emergency use of alpelisib for the first time in people who were very, very sick. And I think the rules in France make it a little, as I understand it, make it a little bit easier to force companies to work with you. So I think that maybe is one of the other reasons he was helpful. But so he described in a very high-profile paper lots of people who got alpelisib, and the results looked very, very impressive. So very, very exciting for all of us. But it also came with all those cautions about the fact that this is not a study where they carefully set out in advance what they were going to do and what they're going to measure. So probably that sort of rose-tinted glasses effect probably is in here. Clinical sort of pictures, and they also did some things to a mouse. Unless, you know, it might be that some of you feel uncomfortable with mouse work, but I would say that they're incredibly powerful in this sort of setting when you really want to try experimenting with lots of things as quickly as possible to get to answers. And you have to wait for years otherwise in people. And so the mice he made weren't exactly mice with prose, but they were mice that developed some of the features of prose. And so he put all those things together. So that was all very exciting. And these were my thoughts when I think this was just before I talked here last time in 2018. And this was just my interpretation of where I thought we were at that stage. So is alpelisib beneficial in prose? Yes, it is, sometimes. Sometimes it seems to be quite spectacular. Sometimes not. This is anecdotes. This is not privileged information. So I don't know exactly how often, whether it's mostly helpful, whether it's not. How big is the effect? Well, we've got some indication that it can be very big sometimes. Sometimes there cannot be so much. But what I can't tell you until we know about the trial is exactly how big that effect is, so we can give you the right advice. How much does it vary from person to person? Again, at this stage we just don't know. And what is the full side effect? Well, it looks very good in those studies, but they haven't registered in advance all the things they're going to write down. This sounds like sort of boring legalistic stuff, but it's just very important to keep us all honest, to keep hope at bay and make sure that we're being very hard-nosed in being able to give the right advice. Is it safe in the long term? Well, I have no reason to think it's not safe in the long term, but again, actually the truth of that is only when people have had it in the long term, nobody can be completely sure. And is it better, the same, worse than other experimental treatments? Well, it hasn't been compared to other things, so we don't really know. And that's why this big trial, which Professor Mansour is going to talk about, is so important. And it's a huge trial, very hard work for everybody involved, all the participants and all the doctors, but it's really going to be very, very important. But in the meantime, it is possible to do some other things. So after that first report from the Paris doctors, the company said, well, it looks like this is doing a lot of good. We're duty-bound to make sure more people get this. And so they put in a process which was registered, where people could get it if there was a big, big need. And that's still available in some countries. And then after a few years, they reported the evidence from that. And the evidence was it still, in many people, seems to be doing a lot of good. It's got some side effects. So it didn't really answer with precision those questions I had, but it began to give a little bit more confidence. And it was after that study that it was registered, so it can be used now in America. And then this is the big follow-up study. I think it's probably the right study. Yes, the big follow-up study which is underway at the moment. And there are one or two other drugs out there on the market, although I think this one is not now studying P3CA. The other very frustrating thing in dealing with drug companies is sometimes they get bought, or they reprioritize, or they sell their drugs, and so you have to sort of have a bit of commercial savvy to follow them around the world. And then the final bit of work which we've done, again, I'll probably jump ahead to my next slide. I think I met Mandy probably in about 2011, and then we and other doctors found out that what the cause of all the problems that we're talking about today is. And actually, over 10 years, a huge amount of stuff has happened. This counts as really, really fast. But the problem is, I think, if you have a 2-year-old daughter or son, it's not very fast, because what you care about is the meaningful timescale that you're working with, not the fact that actually, in terms of making new medicines, this has been fast. And so we have got together with a bunch of colleagues from around the world and at least done our best to make recommendations for doctors out there as to a sensible way to manage all the complications and all the possibilities which can come along with our current knowledge. So really you're going to hear much more about the details of current treatment and about the trial and about research from other people, no doubt with much prettier slides rather than these sort of undergraduate lecture slides. So I just wanted to sort of start the conversation just now. You know, my job is mostly to go around giving talks, and frankly, a lot of the work is done by all these people who worked with me over the years. These were all in Cambridge. Felicia has sort of followed me to Scotland, but not quite to the same place, as she'll no doubt explain. And so many of you here who come to Cambridge to meet us over the years will have met Julie, Lena, and Vicky. So that's really all I wanted to say. I'm sure there'll be questions which pop into your minds, and I'm very happy to answer questions either now or just in conversation if you grab me in the corridor or over coffee over the course of the next day and a half. So look forward to lots more discussion.